Welcome to Brigham and Women's Hospital. I'm Dr. Chris Thompson, and we have a good team with us here today. We have Sherry, one of our advanced endoscopy nurses, Jem Simsek, who's our bariatric endoscopy fellow. We have Marla and Jen and the rest of the team here as well. And we'd like to thank Dr. Siamoulis for inviting us to participate in the live portion of the course. Today we have a case of a 67-year-old male with type 2 achalasia, and he has an Eckhart score of 11. So he is, truly very symptomatic with his achalasia. And he has a complicated cardiac history as well, with a right bundle branch block and AFib and some other medical conditions as well. So they thought that POEM would be a good procedure for him, even with that high Eckhart score. So our approach today is going to be that we're going to start by using an ultra-thin upper endoscope to kind of get the lay of the land. And we'll also be using a new feature of this Fuji scope, which senses tissue oxygenation. So it's kind of interesting. We might be able to see areas of scar tissue that we might want to avoid, and maybe some other things as well. We'll then move on to do an EndoFLIP to get our distensibility index and make sure there's no surprises there. Then we'll move to Radial EUS to make sure there's no other causes, pseudoachalasia, etc. And then we'll do the EPOEM procedure using the Speedboat. And with that, we're going to get started with our upper endoscopy. So here you can see on the screen the larger image is our standard endoscope image, and the smaller image is the tissue oxygen saturation. So right now we're just kind of using the one function. So Sherry, can you please give us a heat map? And let's zero that. Mm-hmm. Yeah. Perfect. That's good. All right. So no real surprises here as far as the saturation. We're getting down to the esophageal sphincter. Kind of snug even with the ultra-thin scope. Here we go. And no surprises here. You can see that's tight. With an ultra-thin scope, that's quite snug. Not yet. And then we're going to kind of come through. Maybe a little erythema here in the stomach. And so we're not catching anything really with that hypoxia overlay, which is good. Nothing jumping out at us as a real area of ischemia, which we wouldn't expect. But we have a more sensitive feature as well that we're trying to better understand. And we're going to cut over to that now. So let's go over to the heat map. And so this is giving us a read. Blue is less oxygen saturation in the tissue, and red is the most. So it's got a lot of blood flow. And you can see here the stomach really looks pretty healthy. It's mostly yellow and red, little orange in there. We're not seeing a lot of blue. So the stomach looks like it's quite nice. No real surprises here at all, which is good. What you can use this for is looking for areas of scar tissue. If something is like really densely royal blue throughout, you might have excessive scar tissue in that area. We do see it a little more blue in the esophagus typically, which we're seeing here, but I'm not seeing anything that's standing out as a solid royal blue color that would make me worried that I shouldn't go in that area with my tunnel. Red here, you'll see here bile, and sometimes fluid can echo red, give you that signal. So this looks quite nice actually, and so we won't be modifying our approach in this patient at all, and we'll proceed with a standard posterior tunnel. All right, there we go. It's a long esophagus. Okay. And here you can see where we're going to be kind of ending our tunnel in the cardia also is really well vascularized with good tissue oxygen saturation. So we're quite happy with this. And now we're going to just get a measurement on the LES. Which is right here. So it's a long esophagus. We're right at 50. So you're right at 50 centimeters. So nice long esophagus. And there's some stasis changes in the esophagus here. He'd been biopsied in the past, does not have candidal esophagitis, but you'll see some stasis changes in the esophagus. He had some food debris as well earlier that we cleared out. So, and with that, we're going to move over to the EndoFLIP. All right, so here we have the EndoFLIP device, and what we're going to do is we know the LES is at 50 centimeters, so Sherry's going to put a small piece of tape here. It can be hard to see these little markings in a dark room, so that'll let us know kind of when we're in the area of the lower esophageal sphincter. And this is not going over a wire. We just kind of advance this. Right down. And sometimes if it's really tight, like this patient, you might have a tough time getting it through that lower esophageal sphincter. Sometimes it'll curl and cause problems. Looks like it's going okay. All right, so you can see we're in position here. And what we're going to do initially is, confirm that we're across that lower esophageal sphincter with, looking at the balloon. So we're going to go up to 30 millimeters. And they're going to push that for me. Perfect. And we're going to look for a waist. So we're using a 325 balloon, which has 16 sensors in 8 centimeters of space. So this is the one we use with endosurgical procedures rather than a diagnostic catheter or a dilating catheter. You can see we're getting a nice waist right here. Perfect. So now what we do is we'll adjust the balloon if we need to, which I'm pulling back a little bit. We don't really have to adjust it very much because it seems to be quite in the middle. We have a nice waist that's presenting itself here. So now we're going to go up to 40 millimeters. Then at this point we'll wait about 30 seconds and we'll be able to start taking our readings. So what we're looking for here is distensibility, so the distensibility index. We're going to look at cross-sectional area, and we're also going to look for signs of contractions, in particular repetitive contractions, either antegrade or retrograde. And that's kind of how we make diagnoses with this. It's EndoFLIP topography. We're really starting to come down a little, even though I've been holding traction on it. So if we need to, we can come down in that balloon again, but I think it's okay. We're at 30 seconds right now. All right, so we're going to pause now and get a reading. So our distensibility index is 0.32, which anything less than 2.8 is abnormal and suggestive of potentially achalasia. The diameter is 5 millimeters. This is with 60.6 millimeters of mercury of pressure, and we're not seeing a cross-sectional area, and so that's rather significant. We can run live again and see if, yeah, and we can run live and see if there's any sign of peristalsis. It looks like there's not. We just have this high pressure zone, and we're not getting any propagation of peristaltic waves at all. So this is consistent with achalasia and the type 2 achalasia diagnosis that was made on high resolution manometry. So now let's go down to just a little bit so I can reposition. So we're waiting 30 seconds again. And we can now pause. We can now pause. All right, we're paused now, and we have a distensibility index of 0.5. Our diameter is 5.9. This is with a pressure of 55.1 millimeters of mercury, and again, we just don't have any. We don't have any peristalsis. The cross-sectional area is 19.2. So clearly very consistent with the diagnosis of achalasia. No surprises here. You know, we're not seeing, you know, two different high pressure zones or anything like that. So we can come down, and with that, we'll move on to endoscopic ultrasound. So as we're changing scopes in the background, what we're going to do is wait for this to drain out. So there's only 10 cc's left, and then it's safe to remove. And we'll also save this balloon so we can do repeat measurements at the end of the procedure. All right, now we're moving on to EUS. And we're using a radial probe. And we're going to go down and position ourselves across this lower esophageal sphincter. And we know it's very tight. You know, it's around 5 millimeters, so we're not going to push real hard. And sometimes you can inflate that balloon a little bit. See right here. Inflate that balloon a little bit and then bring it down, and it helps get you in. We're going to suction this down. And we're going to see what we get here for an EUS image. And we're putting up that balloon, and now we're going to kind of pull back in to the esophagus from the stomach. In real tight achalasia, you can pull this balloon right off, so I might have to deflate it if I need to be able to pull this back without pulling it off here. But you can see there's no sign of any thickening or abnormal masses in here as I'm coming back through. Now I'm going to come down on that balloon so I don't strip it right off the end of the scope. But that looks entirely normal, which is good. You know, we don't want pseudoachalasia or a cancer or something in here. I think I'm kind of through, so we'll blow it up. You will see some thickening in the muscle layer in some patients, of course. Look at our tissue planes as we come back through here. Maybe a little thickening at the bottom, but again, no abnormal lymph nodes are coming into play here. There's no sign of a mass. With that, we will move on to our poem. All right, now we've converted over to our endoscope that we're going to use to perform the poem. This is a Fuji single channel therapeutic scope called the CT scope, and it has a 3.8 millimeter channel. Has lots of other features as well as far as your imaging capability, which we'll talk about. We can adjust the iris and do some other settings as well. So I'm coming back down kind of through that lower esophageal sphincter, and we're going to mark this. So what we're going to do is, again, we're showing this to be with a smaller, less rigid scope. We were at about 50 for this, and with this scope, pushing down just beyond the cap there, we're at about 48. So what we do at this point is, I'm going to have Jem put a piece of tape on here, knowing that once I cross this tape, I'm probably pretty good. So that's right at our lower esophageal sphincter. Then what we're going to do is we're going to back up a ways and try to figure out where anterior and posterior is. And we're going to put a line on this tape to help us keep oriented. We're going to put a little bit of fluid down. Looking for a pool of fluid. It's really kind of right below us here. And he's really lying in a supine position, slight elevation of that right shoulder, if any, so we know this is posterior. So with that, we're going to put a line on top of this tape so it keeps us kind of moving straight. Prevents us from twisting in the tunnel and moving around laterally in the in the esophagus. All right, perfect. So this is excellent because it keeps us kind of running straight and keeping a short, straight tunnel. And with that, we're going to get started here. So we're using a novel technology today to do this EPOLM procedure, and it's called the Speedboat by Trio, and it's quite an interesting little system. It uses different waveforms so that we can do this procedure in a bipolar fashion and not run the current through the body like we normally would with other devices. And there's advantages to that, especially when someone with a cardiac history, and you might be concerned about it, if they have an AICD in place, a pacer, etc. Our patient has a bundle branch block, so it's something that we're particularly, interested in and thinking about. So, and here it is. You're going to see it better actually, through the endoscope. But if you can zoom in on it, it's a 3.7 millimeter device, so you do require a 3.8 millimeter channel. However, on the way, I've seen these newer devices are much smaller. And they'll go down to 2.8 channel, which is great. It also has an integrated 26 gauge needle, so we'll show you that as well. So, all right, here's the device. So you can see here why they call it a speedboat. You have the electrodes for the bipolar energy are running between that gold portion and the hull on the back side, which I'm going to rotate a little counterclockwise. You can see the hull back here, right? So that's kind of your cutting surface is kind of that top edge where the white portion meets the gold portion. And then your microwave for vessel sealing really runs around that entire hull at that white portion. So you'll see this as we go. And we're going to select our site for access now. So we know where posterior is because of that line. That's what we've decided to do on this patient. Esophagus is pretty straight. It's not terribly sigmoid, which is nice. But I do have to keep kind of my little wheel forward as I'm going down to prevent myself from spinning around to the left. We don't need a terribly long tone because this is type 2 achalasia, not type 3, so I'm not too worried about that. So we're going to start just a little above 40. So let me get the catheter out here. Let's rotate it hull side up. So Sherry's going to be doing a lot of rotating here. And she tapes, what are you doing here? I don't know if you can see what she's doing.
This is a Coban, so it's like a sticky elastic. We use it to wrap up bandages and various wounds and stuff. But
so she's applied Coban to this.
Gives traction.
Yeah, she's applied Coban to this so that it's a substance that sticks to itself. So she can make a nice little handle here that helps her turn the device. So we're going to rotate it now whole side up. There we are. And now you can see the needle. And she's going to put the needle out gently. Let's pull it back. I'm good here. So I'm going to come back just a little bit more. That looks like a good spot to start our entry point here. So what we're going to do is I'm going to suction just a little bit, and she's going to start injecting fluid. Yep. And then when I see the fluid start to spray a little bit, I'll advance this. So she's injecting this under some pressure for me. I want to make sure we got a good lift here. Inject. Yeah, inject hard right there. There we go. Keep injecting. Nice. How much you have in there? Okay, that's enough. So we have 3 cc's in, needle back. And a nice little submucosal cushion there. And we're using head of starch today with some methylene blue, no epinephrine. And we'll show you the system as we get going, how we're doing that. So now we're going to make our incision. You always think about how you're going to close when you make your incision. I'm just going to put some clips down, so I'll just make a nice kind of longitudinal incision here along the length. And the cushion seems a little bit to my right, so I'm going to cut with the right side of the device. So I'm going to kind of come out a little bit more right about here. And that looks like a natural position to be cutting. Everyone agree with that, by the way? Okay. Looks like a natural position to be cutting in. So I'm going to use my yellow petal and make an incision right here. You can see we're right in that submucosal space. Now it's natural to get some bleeding when you're doing that, so I'm going to actually keep it right there and step on the blue petal. Now this is using the microwave. Before it was RF, now we're using microwave. And you'll notice we step on this for a longer period of time because it's lower voltage and it does get very hot. You can see we had a nice little white area of ablation right there. We're going to do a little bit more. Yeah, nice. So we got it there well. Okay, very good. So now we're going to insert ourselves into the submucosal space. Inject some more here. All right. Perfect, yep. Right side down, please. No, we keep it left side, it's okay. Right side down a little. Perfect. Maybe the last, there we go. So, this is perhaps a good time to show you how we're injecting. We're not putting out the needle when we're in the track to inject. You can, but we find it works without doing that. And we advance it in, and then what Sherry is doing, if we can get in on her hands, is she has a nice system here set up where she has a 5cc syringe hooked up with a stopcock to a fluid bag, and that's where she has the head of starch mixed. And what she'll do is she will empty the syringe down the channel, of course, of the device. Yep, go ahead. We're going to do an injection here. And then she generally will count off, 1 cc, 2 cc. She's doing that kind of quietly over here. And now I know we've gotten a few cc's in. And what she can do, we'll show you how she fills that syringe. Normally she'll wait till it empties, but she can fill it now when there's downtime. And she kind of flips the stopcock and just pulls it right out of that IV fluid bag. All right. And with that, we'll continue doing this. You don't keep a lot of the knife out, just like most procedures, Maybe right side down a little bit more for us there. Nice. Left side down. All right, now time to talk about the endoscope that we're using. We already mentioned that it's a single channel therapeutic scope with a 3.8 millimeter channel. You can actually see that right on our screen. So on the screen itself, I'm not sure if you can see it over here, but there's a small image that has the channel size, the location of the channel, which is very useful, as well as the scope type and other important features. But there's also some interesting imaging options on the scope. So one of them is you have different light options. So this is we're going from white light now to LCI, which is linked color imaging. And what this does is it really exaggerates, your reds and kind of diminishes the blues. So you're getting more separation. It's great for identifying lesions. Okay, so this is something they're using in their AI technology to identify lesions. And then BLI is blue light imaging, which enhances your blues predominantly, is better for characterizing these lesions. And so you have a few different options on the scope. I have actually played around a little, back to white light here. I've played around a little using LCI. I'm thinking it has helped me also identify blood vessels a little better and these tunnels. So that's something we might shift to for a little bit of time here during this procedure. Another thing that's very helpful with these scopes is the iris. We can adjust the iris. And right here, we're doing averaging right now. Okay, right here we went to auto. So with auto, it's generally something that you're going to use for doing a colonoscopy. It tries to spread the light out pretty evenly across the field. We have peak. Peak is something where if something is in the distance you really want to see, you're going to go to peak. And if you're not as much worried about scatter in the foreground. And then the averaging, which is what we like, we tend to use this when we have a cap on the scope so that we don't get a lot of issues with artifact from the cap being bright and then being dark in the distance. With that, we're going to get back to our tunneling. We'll keep it oriented just like that. I kind of like that positioning. We'll just go on the left for a little while. Right side down. So now we're going to talk about another way to use this device, and Mohammed Atman has been kind of exploring a new way to use this, where he flips the whole side up, or he rotates the scope so the whole side is up towards the mucosa, because again, we want to protect the mucosa from injury. That's our, one of our main goals when we're making a tunnel. So we can kind of flip this around. So Sherry, if you'll rotate that clockwise so the whole side is up. And keep in mind the cutting surface is specifically where the gold area meets the white area, so not the white in the hull here. So we want to make sure that area is pressing on the tissue as we do our dissecting. And so we can hit it, kind of over here as well. It's another effective way to kind of do our tunneling here. Quite nice. Yeah, you can be a little more aggressive with your submucosal incisions, if you will. Keep it rotated a little more down. Don't rotate, please. Yeah. Here we go. I'm going to keep working the left side. That's good. And come down in here and inject a little more. Yep. That's nice. Keep going. Excellent. Okay, cool. Come back and take a look. Interesting. So Sherry's noting that you see the injection coming out better when we're upside down. That makes sense. Even without the needle out, it's just a little easier to see. All right. So we'll keep it just like that, and I'll go to the right. Maybe a little less rotated. Here you are. Yeah. A little more counter. So these waveforms tend to work better in a dry environment, so we don't want to do necessarily underwater procedures with it to be a little less effective. So we're being mindful of that as we go about making our tunnel. Oh, no, it's okay. Line's still facing up, so that's a good sign. And we're at our tape. We're really dropping into the stomach here. Might make this a little bit bigger because we might be going back with a standard cap rather than a tapered cap. It's a little easier to do the myotomy with that. So we might widen this up a little as we go. Take these down. Yeah, it's okay. No, that's fine. And let's, I'm going to try to go this direction now. A little deep there. Staying in that submucosal space there. And we're going to go to the right for a little bit here. Yeah. Nice to get above that if we could. A little piece of muscle. I don't know. Okay, we'll go that way. That was... Okay, we got some bleeding behind us, and we'll take a look to see where that's coming from. Now we got bleeding. We'll go back to our white light. Doesn't look as dramatic. Kind of right behind us here. And maybe decrease the flow a little bit more, please. If the flow is too high, it's disruptive and you can't really see where the bleeding is coming from. Yeah, it looks like it's coming from this general area, so we'll start with just an ablation here. Works off the tip of this as well, which is nice. We're going to put the tip kind of right on it. Go with the blue pedal. Looks like maybe off to the left we got something too, unless it's tracking around. Not right there. Okay, stop that one. Yeah, sure is noting that it doesn't really stick to the tissue. You don't get charring, it doesn't stick to the tissue. Nice advantages there. And we're beyond our tape by a couple centimeters. We'll go a little bit further, but we're probably 2 centimeters beyond. We'll go 1 more centimeter beyond. Go ahead and inject. We get 3 centimeters below that LES. Give yourself a little extra room. Okay, good. That's good. Let's rotate it up a little bit more because I'm going to go from left to right. Yeah, right side up a little. Nice. There's a vessel right there, but we're going to try to cut. Kind of avoid it. Now we're going to actually ablate it, actually. Good. This is great. Left side up just a hair more. There we go. There's a vessel right there. We're going to probably skip that for now. Getting a little deep. So go ahead and inject there. There we go. Perfect. Thanks. Let's try to stay above that muscle there. That's a good spot. Above the muscle. There we go. Oh, a little bit of blood there. Red bile. Oh, there it is. An example of bleeding from one of these perforating vessels down here. So we're holding pressure on the site with the cap to tamponade it. We're going to place the probe end on here if we can. It'd be nice. We get a little bit higher. This is a hard thing to do when you're using one of these, a larger scope and a conical cap. It's hard to get elevation. Good now, yeah. And we're at 51, and that was at 48, right? So let's go double check. So we're going to come out now and double check that we made it through. Yeah, we're going to take a look. Nice tunnel there. Yeah, let's take a look here and see. Sometimes it can be hard with this cap in particular. So here we're going to a retroflexion here, and you can see our tunnel is well beyond that lower esophageal sphincter. So we've made it into the cardia a decent distance. Some people will gauge this as they're doing the procedure, and they'll put a small ultra slim upper endoscope down and kind of have one in the tunnel and one out to make sure you've made it far enough. But clearly we've kind of tunneled far enough here, and I'm comfortable that we can proceed with the myotomy now. So we're going to come out and change caps for this part of it, just because it's easier to get separation of the mucosa from the muscle layer when we're using this device, and we'll talk more about that in a second. All right, now we're going to be going back to our therapeutic upper endoscope with a standard cap. And here is our access site. Into our tunnel. All right. So we're going to start a couple centimeters distal to where our access site to our tunnel ends, and a few centimeters above the LES. Like 4 or 5 here. With this, we're going to try to do a partial thickness myotomy here, just kind of taking predominantly down the circular. We might go a little full thickness the lower we go, and it can help to inject fluid to do that. So what we're going to do is we're going to kind of not putting out the needle. We're just going to insert the device kind of into this area and inject a little bit of fluid, maybe a cc, and see if we can help separate these layers. Okay, that's good. That's good. We'll see what that looks like. So keep in mind, as we're cutting, you can cut on the top surface as well as on the bottom surface with this device, where the white meets the gold. Kind of right in that edge is where we're cutting. So you want to be mindful of that as you're making an incision here, or whenever you're using the device in a cutting mode. A little bit counterclockwise. A little bit more counter, maybe. Yeah, so I'm going to try to come in and come up like this. Like that. And so we see we still have some circular layer here. We keep taking that down little by little until we get in our spot. A little more counter, please, Sherry. There we are. That's perfect. So do a little bit more there. Almost. Still got some more there. A little more counter. And gently find this area. I think that might be it. We're getting close. And right here, a little more counter. I want that corner right there. Okay, we'll keep working. I think we have a little more to do there. We'll keep working here. So Sherry's mentioning you got to constantly hold a little bit of tension on it so it doesn't fall back to a neutral position. That's a good point. All right, we're going to continue. So there's a couple of different ways we can do this. We can, kind of use the device itself and position it, or what we can do is we can kind of use a scope. So once you kind of get in that plane, you can kind of just use a scope and gently advance the scope like this, and kind of just keep going down. Making sure that cutting surface is in the right location and that you don't get the device out too far, which can be problematic. Keeping in mind this is a bigger scope than you usually use to do this procedure, so that's something you gotta remember. We're kind of carefully advancing, not getting too deep. Have to go a little bit deeper here, it looks like. Rotate a little more clockwise for me, Sherry. Just a little, there you go. Kind of advancing the scope as we go. Trying to stay in that plane. Yeah, a little clockwise, yeah, exactly, yeah. So here, as we're getting closer to the LES, where the tension's highest, and you got, sometimes it's a very narrow tunnel, it's very helpful to have a standard cap, because the tapered caps really don't provide enough separation, and you're more likely to hit that mucosa up above. So we want to be very careful of that, and the standard cap does seem to help in this regard. So you can see it's really keeping that mucosal layer away from us up there. It's doing a very good job. I'm very appreciative of the cap right now. I'm going to keep going a little deeper here. There's a narrow margin for us right here. Rotate a little more clockwise. That's perfect, I think. No, I think it's good. A little less. Yeah, it was good. Kind of right in here. And coming gently right through here. Maybe a little. You can be quite precise with the device. There we go. We're going to want to take this down. Sometimes here's more circular right here, obviously. A little more counter. There we go. Nice. Maybe we'll take some more of this down here, actually. So it seems quite snug, doesn't it? All right, we can go a little deeper in here, it looks like. So rotate. Yeah, that's perfect right in there. That's good. I like it. Trying to keep it as close as I can, but sometimes you need to go out a little farther away. Yeah, true. And rotate a little counter. Yeah, perfect. All right, I think that's about it. So I think we're at the bottom here. Looks pretty good. Make sure there's not a lot of bleeding. It's pretty good down here. Kind of want to take more of this right here. Now we already did cut through most of this, but it looks like there's a little more we can do kind of right in this area. Right here. And right here. Huh. So whatever that is perfect. It wouldn't change a thing. That looks pretty good now. Yeah, it's nice. So looks pretty good. Have a nice long myotomy. Our myotomy is going from about 44 centimeters down to about 52. So we're good with that. Looks like it is aggressive enough. There might be a few more little things we can take down here, but and this is where someone usually says the enemy of good is perfect, which is always good advice. I always like to check for crepitus or any abdominal distension during the procedure, which we're not seeing any of this time, which is nice. Flatten out a little bit more to counter. Here we go. I'm going to take some of this down right here. A little flatter, please. Left, counterclockwise. Thanks. This area just looked a little tight, so you want to do a little bit more there. All right, that looks good. So, with that, we're going to just look for any more vessels to seal, and I'll go back over to LCI. You see those blood vessels kind of pop a little bit. And it looks pretty good. All right, and with that, we are done with the myotomy, and we can get on to repeating the EndoFLIP to make sure we've had a good enough effect. And then we'll close. Okay. Going down through the lower esophageal sphincter. There's no resistance there, which is nice. Not seeing any big mucosal breaks, any full thickness kind of damage. Just a little bit of redness there, but nothing bad. So, and we'll go back over to the EndoFLIP now. Yep. So we've changed back over to the EndoFLIP. We have a nice integration system here. We have these all these different tools and toys kind of plugged into the same system that Fuji's helped us set up. So it's really helpful in making these transitions as efficient as possible. And going to advance the catheter down just a little ways. We don't want to go all the way because it might slip out into the tunnel and cause some trauma. So after getting it in, short of our access site, we're going to advance the scope down and to double check that it's in the lumen of the esophagus and not in the palm tunnel. So we're going to switch back over to this. So we're going to go to 30 to, again, make sure we're in the right location. Yes, please. So we'll insufflate the balloon. And let me take a look. Yeah, I'll hold it. Looks like it's probably, make sure it stays in the right spot. Yeah. Perfect. So it looks like we have our waist about the right location here. So we'll go ahead and go up to 40. And hit it there. All right. So we have our measurements post now. Our distensibility index is 3.32, so that's pretty good from coming up from sub 1. You don't want to go too aggressive with it, or you might be more likely to have reflux. So we're back in the normal range, so I'm happy with that. Our diameter is 10.5. Again, that's pretty high as well. Pressure 26.1. And do we have a cross-sectional area? 88.2. So that's quite a nice treatment effect. We can come down with the balloon now. So our distensibility went from 0.32, up to over 3.32. So that's a good improvement. Pressure went from 60 to 26. Cross-sectional went from 19 to 88. So and doubled our diameter from over 5 to 10. So that's a good improvement. So we're coming down to 10 millimeters. We'll remove the balloon. 10. And we're going to go back and close this now. All right. You go back down. So little zipper technique. We'll start at the bottom of this. And open. And we center it up a little to the right. So we're going to try to center it. We'll push down, suction, go ahead and close. She can close without firing. And then I'm going to push out and take a look at it. And that looks like a good starting point. So she's going to fire and release the clip. And then that's where we'll start. Again, assessing the anatomy, zero crepitus and a nice soft belly. That's nice. Not always the case, of course. You got to expect pneumoperitoneum and some crepitus in these procedures. It's nice when it doesn't occur. Okay, so I'm rotating that myself, you'll notice. Not too hard to do. And sometimes the nurse rotates it as well. So let's go counterclockwise and fix that. There we go. Nice. Okay, go ahead and open the clip. And kind of pushing in, suctioning down. Go ahead and close. And we'll look at it. Looks like that's nice. Got both sides, fire and release. And we'll continue. Different things to think about with access and closure. If you're going to suture this, and you are running a stitch back like this, you could really reduce the width of the esophagus. So if I was planning on suturing this closed, I'd probably make a incision kind of horizontally across the esophagus instead of longitudinally down it, because then I can close anterior or distal to proximal, and it'll just shorten it a bit without reducing the width of the esophagus in someone that already has motility issues. With clips, it's not as much of a problem. You're not grabbing as much tissue typically. Okay, open. Give you a little bit here. Close. That looks good. Fire. Yeah. All right, take a look at it now. You might put another one down. We'll see. And sneak down along the side of it. Make sure you got the whole thing. Looks like we do. About way down here. Is that a clip right there? That's a clip, 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 clip. That looks good. So look at the other side as well. Check the other side out as well. All right, and with that, we will go evacuate the stomach, decompress it, make sure they're comfortable at the end of the procedure. Look at the clips one more time on the way out. Quickly there, look good. And that's the end of our procedure. So thanks very much for joining us today. I hope you're enjoying the conference. And hopefully we'll see you actually in person next year. And thanks for the entire Brigham team.